Good afternoon. Welcome to Medical Grand Rounds at the University of Colorado. To the audience that is just joining us, we're going to wait one more minute or so for everyone to log on and for our speaker to be ready, and then we'll get started. So please just hang tight for another minute or two.
Paul, welcome. Can you hear us okay?
I can, and a million apologies for the delay.
Not at all. We're waiting for you and happy to have you here. And I'm going to turn it over to Dr. Peshla to get you introduced and get us started.
Dr. Farmer, I'll say welcome as well. And you can't be late to your own talk, so don't worry about that at all. It's good to see you. Thanks for doing this again. I want to welcome everyone to Medical Grand Rounds at the University of Colorado. I want to remind everybody that CME and mock credit are available for the talk. You can use the link that Kelly put in the chat. I want to also remind people to use the Q&A feature. The medical chief residents and myself will gather your questions for Dr. Farmer at the end of the talk. And with that, I will turn it over to introduce the Tim Gill lectureship, as well as Dr. Farmer, to Dr. Eric Peshla. And Eric, you are muted. Sorry.
Thank you. Thank you, Jeff and Vineet, and welcome, Paul. Before I introduce Paul, I want to say a few words about Tim Gill, who endowed this annual lecture series. And it does strike me that Paul and Tim have each, in their own singular ways, spent lives much concerned with inequality and enabling pragmatic solutions to it, and inspiring and teaching others to do the same. So what about Tim? Tim is a Colorado entrepreneur and software engineer who 27 years ago, during the most desperate years of that other great emerging virus pandemic, the HIV-1 pandemic, endowed the Gill Professorship in HIV Research and this associated lecture series. Tim has since gone on to focus on countering discrimination based on sexual orientation and gender expression, and his foundation has been a major factor in advancing acceptance and human rights for the LGBTQ community across the nation. The Gill Foundation pushes beyond exhortation and advocacy to enable concrete outcomes in education and in electoral politics. And so also in his own kind and insightful way, and guided by his own compass in different times and places, Paul Farmer has studied and enabled good change. He is currently the Colacatrones University Professor at Harvard Medical School, where he is also the chair of the Department of Global Health and Social Medicine. He is both an academic physician and a medical anthropologist who has worked extensively on issues related to healthcare equity in developing countries, particularly on HIV and tuberculosis, and more recently, Ebola. Paul has in particular done much important and sustained work in Haiti, which is the poorest country by far in the Western Hemisphere. And there he's practiced medicine, built care infrastructure amidst very challenging circumstances, and implemented and sustained antiretroviral treatment year after year after year. And he's also published much research about that and the experience of suffering and its sources in poverty and political oppression. Paul was awarded a MacArthur Foundation grant at age 34 for his work in medical care and infrastructure in Haiti. You show next slide. Now, healthcare in Africa, sometimes in regions he has called medical deserts, has also been a preoccupation. He is right now at the Butera Hospital in northern Rwanda, where he's been seeing patients and teaching this week and attending a groundbreaking celebration at the new Rwandan University of Global Health Equity. He's also attending the white coat ceremony for the first class of matriculating students there. Paul's scholarship is including writing some 12 books along the way, and he just wrote an important book about the Ebola crisis 6 years ago that describes his work in Ebola treatment units while analyzing historical antecedents and, importantly, how Africans themselves experienced that epidemic. And I highly recommend it to you as well, a book about Paul in Haiti, Tracy Kidder's biographical Mountains Beyond Mountains. In all of this, Paul's been an indefatigable champion of the poor of the world and of insisting on striving for the same level of medical care that we are privileged to have here. To that end, he is also the founding director and chief strategist of Partners in Health, the Boston-based international nonprofit that works in healthcare research and advocacy on behalf of people living in poverty around the world. So we thought this pandemic year seemed an ideal time to invite him as we think about solving the current global imbalances in vaccine administration and effective medical care, as well as the major secondary impacts the pandemic has had on HIV and tuberculosis care. Paul, we're honored to have you.
Dr. Farmer, you are muted as well. I apologize.
Hello?
Perfect.
Oh, goodness. I just got a new microphone, so I thought if I'm in trouble if this is not working. I was just saying I want to thank Eric, but also all of you for allowing me to give a lectureship in honor of Tim Gill. And I'm going to, having had the opportunity to speak earlier, give grand infectious disease rounds earlier, and talk about Ebola and COVID, I'm going to just focus a little bit on some of the lessons learned in the course of, being involved with many, and by the way, Partners in Health has 20,000 employees, and I'm actually not even one of those. And in Haiti, for example, there are over 6,000 Partners in Health employees, and they're all Haitian. And so that'll be part of the background to how do you build out enduring healthcare systems that are focused on the needs of the most vulnerable, and that is often the poor. So I have the next slide, please. Hello?
The next slide is up, Paul.
Okay, thanks. This is kind of a busy slide, and I don't ask you to read it, but after almost closer to 40 years than 30 of doing this work, you notice a number of patterns which emerge again and again, and I'd like to signal them here and bring them out in the course of the discussion. We hear, for example, again and again, that an ounce of prevention is worth a pound of cure, and then it's used as an excuse to not do both. We hear, at least I've heard in working in the clinical desert, that the absence of specialists is a barrier to providing care. I'll give the example of some of the absurd things we heard 20 years ago after the development of effective antiretroviral therapy about AIDS care in Africa, that we needed more infectious disease doctors, which didn't seem to be true. It's not an undesirable thing, being one, but there are plenty of ways to deliver care more expeditiously than through the model that's been elaborated in the United States, or that weak infrastructure should be an excuse to not bother trying to build that infrastructure or to strengthen it. And then there were some really shocking kind of arguments made about, for example, was it cost effective to use whatever countermeasures, medical countermeasures we had? Let me just stick with the example of HIV, that the drugs were too expensive. And then modeling done by academics, a lot of them in public health, in fact, and many in health economics, showing that it wasn't cost effective, and using and conflating in these analyses the price of drugs in the United States or elsewhere and the cost of making them. And it wasn't really until there was sustained action on this front that led to the provision of generic medications, and so the cost dropped substantially. I'll show some examples. And a complete unwillingness to think about what the cost of inaction is. Like, what does it mean to have a pandemic like HIV, the leading killer of adults and children across a continent, and the leading infectious killer of young adults in the United States by the time I've finished my training in infectious disease? It's the same story with COVID, but it's made more dramatically. There's enormous cost to inaction. And then these confident claims that something is not sustainable as a means of stopping the discussion rather than starting it. So I'm going to try and bring out these themes just in looking at some of the programs that I've been involved in and that others have been too. Next slide, please. And forgive me for starting in a somewhat biographical way. in between college and medical school in the year 1983, I spent much of it in rural Haiti. It was a very great place to learn because I ended up in a squatter settlement. And I thought that squatter settlements, being a, just recently graduated undergrad, I thought squatter settlements were urban phenomena. But then I found by going to central Haiti, I ended up living in a community of refugees, as they call themselves, water refugees, when a fertile valley was flooded to build a hydroelectric dam that brought neither water nor electricity to those who had been displaced. So the very notion of a discussion of cost effectiveness or sustainability or feasibility is in many ways best examined in a setting where there's so few resources available to those living there that these seem like somewhat absurd constructions. Next slide, please. And I started talking about this experience earlier today, and I'm going to go back to it for a second. So in 1988, we launched what we thought was a pretty good tuberculosis care program, meaning that tuberculosis diagnosis and treatment was considered a public good for public health. You didn't pay for it. You had symptoms consistent with tuberculosis or a diagnosis of tuberculosis in this particular clinic. You didn't pay for anything, not an x-ray, not the medications. Back then we were using one injectable medications and not even that. But we still found that we were losing patients after patients. And in the year 1988, about two years after this clinic was open, in this small squatter settlement, we lost, or in the area right around it, in this an area we had identified as our immediate catchment area, we lost 3 healthy young adults to tuberculosis, previously healthy. It just so happened that they did not have HIV and co-infection, but these are people living right there in our neighborhood. And so this launched a series of debates that many of you will recognize today. Thinking about Ebola and the experience I was talking about earlier, or our current discussions, public and popular discussions about COVID right now. So let me just Bowdlerize this a bit and tell you what it felt like to me. And I was at the time, as I shared with the ID division, I was a graduate student of medical anthropology. And so what do anthropologists do? They chat with people. It's a pretty great field if you can get a PhD out of just talking with people. It's one of the reasons I like it. And so we set out to launch first to have this series of meetings, community meetings, to ask, well, what went wrong? If you have, just as we would do at M&M's, in Denver or Boston. And there was a kind of split between the let's say 50 or so people involved in this work. And it seemed to me to be a split between the recognized healthcare professionals, the doctors and the nurses, and the community health workers recently recruited and trained, but who shared the social conditions of most of the patients. That is, they were rural, or most had not even hadn't completed high school. And everybody spoke Haitian Creole, but very few people would be comfortable speaking in French, for example. And that split suggested to me that the healthcare professionals, my peers, or the people I was about to join their peer group, were very quick to blame poor compliance or lack of adherence on superstition or something else that was located in the culture or the person or the comportment of the patients who were treating. And there was a fairly brisk objection from many of the community health workers who said, no, that's not the reason that these people are failing therapy. It's that it's not that they can't get free tuberculosis meds. It's that they have other problems that lead them to leave this area, for example, to go to the Dominican Republic, to go harvest crops elsewhere. As market women, they were too poor to stop that work, too poor to find transport to the clinic if they were feeling unwell, meaning transport by donkey. Actually, when we published this paper, I think I may have introduced the term donkey rental fee into the medical literature. And so we designed something. We didn't think of it as an experiment, or really a study, but we said, let's compare the experience of those living in this catchment area, who we will not only make sure there's no cost involved in their medical care, since tuberculosis treatment is a public good for public health, but also nothing for transportation. They would have community health workers who brought the medications to them. They would also have financial assistance and nutritional assistance. And even today, trying to do this is often met with a chorus of complaint, never from the patients, but mind you, but from the experts who deem things cost effective or not cost effective. And this was a very inexpensive program just to provide those basic services. For those outside of that sector where we did have staff and could ensure access to nutritional and financial aid, we still had free tuberculosis diagnosis and care. And we said, we're going to follow what happens in terms of mortality, in terms of varied ways of measuring tuberculosis outcome. They're not very sophisticated ways, but smear microscopy, and even that radically difficult thing to do of weighing the patients. Could they resume their jobs? Did they show up for the clinic visits that we did ask them to go to, which was once a month with transportation included? Would we be able to see a difference? And it wasn't long before we saw a very predictable difference. It was just a bit larger than we thought. In that first group, we lost one patient, but not with evidence of active tuberculosis as the cause, and that's why the cure rate, even with that patient, is that she was in the cured category. But you can look at this chart yourself. We could say fairly confidently that pretty much everyone had, by our definitions of the time, 1 year disease-free survival. In the other, documenting survival was difficult because many were lost to follow-up. Many remained also smear positive, almost 20% after 6 months. And by the way, the rate of the speed of smear conversion in these patients who had largely what we believe to be, and sometimes documented to be, pan-susceptible disease, was often within days or a month. So 6 months of positive smear microscopy at 6 months was clearly indication of treatment failure. Also, many had symptoms. Some had asthma, some had chronic cough, even occasional hemoptysis. They weren't able to return to work, half of them. And so we really felt that we could only say that 48% had been cured by this mode. And this was before the expansion of what got called DOTS, directly observed therapy short course, which had its own problems, which will come up later. And that taught us something very important, that the goal of these programs shouldn't be to change the patient, it should be to change the care delivery system. Now, as an anthropology grad student, of course, I couldn't resist asking about what the professionals had called superstition. And what I found, and these were interviews that often took place over months. In other words, it wasn't just one document. It was months and months of really talking about it. Sometimes you'd have people reveal something to you after they got to know you, as is hardly surprising. And we found that in neither group in both groups, the great majority did not deny the role of sorcery in their illness. The point is, it just had no bearing on the outcome of the treatment program. It was the treatment program and not their ideologic or explanatory models. It was the strength of the program. So this, every few years, we have to sort of remind our professional colleagues of this. There are new crops coming in regularly, and new cohorts coming in regularly. But the stalwarts of this program, many of whom still work with Partners in Health to this day, became, let's just say, somewhat militant, I among them, about asking our colleagues to not pay so much attention to the alleged deficiencies, cognitive or otherwise, cognitive, cultural or otherwise, of the patients. So that's sort of a backdrop to the programs that we expanded, which of course were soon integrated with HIV care. Next slide, please. And just to give an example, of why we did what we did, and many others did as well, particularly in Southern Africa, although again, there were very few AIDS programs and none that included ART, even though AZT had been around for a while and been shown to reduce mother-to-child transmission quite dramatically. As you can see from this chart, and this is just 200 sequential HIV diagnoses, that when they come in, they have a positive serology. What's their presenting complaint? We felt that more than half of them had tuberculosis. And although this wasn't widely reported in the literature back then, it soon became clear in American cities and South American cities, as well as Asian cities and across Southern Africa, that this was a very common pattern in areas where there had been endemic TB. Next slide. So the programs that we developed for HIV patients, first of all, we started in many of them by treating their tuberculosis. So they were in the tuberculosis programs, but structurally, these were the same programs. And then, of course, the year that I finished my infectious disease training, 1996, was a big year in HIV care. And it was the clear evidence that a multi-drug combination of antiretrovirals would radically suppress mortality. In the United States, which, as we've all learned over the past 2 years, has a very weak public health delivery system and a very weak system of insurance, health insurance, particularly for people of color and people living in poverty, even then, the fall off in mortality was dramatic and welcome. And I can just remember this personally as a resident and as an ID fellow. As a resident, you know, our teaching hospitals at Harvard were full of young men and women dying of HIV disease. And then after the mid-90s, we didn't see them as inpatients very often, but rather in outpatient clinics, or unless we bumped into them socially. So this was another big lesson. Lesson one, don't blame the patients, focus on the program deficiencies. And number two, make sure and take note of new developments in the world economy, new good developments like new medical countermeasures and therapies. Now, this meant that in those areas where those medications were unavailable and also not even recommended by the public health specialists because they were, again, deemed not cost effective, not feasible, not sustainable, et cetera, this meant that the overall misery triggered by this virus began triggering even more problems wherever those therapies were not available. And you could call this an equity gap, because when a new technology, and think about the COVID vaccine, of course, when a new technology or medical countermeasure is developed, if there is not an equity plan to distribute it based on need, then you will see a widening outcome gap. And again, this is a lesson that has been learned again and again since the 19th century and all through the 20th. And it was a very painful lesson at the close of that century. Next slide. So what was to be done? Well, let me just say that a lot of the alleged superstitions that I've been hearing complaints about from my Haitian colleagues, I was working with Haitians, not really so much with non-Haitians in Haiti, were not a patch on the kind of superstitions we heard from experts. And, you know, for example, you know, you saw these comments from people in powerful positions. I mentioned the US AID chief, because that's the largest development assistant branch of the United States. I took off the names of the people because I don't wish to, you know, antagonize an individual. This was widely, we were swimming in this. This was everywhere. It's not feasible, it's not cost effective. And you can see the same reasons given that I summarized at the beginning of this talk. Next slide, please. So how do you tackle immodest claims of causality? That is that whether it's superstition causes bad outcomes for tuberculosis or Ebola, or this is not feasible because people don't know how to use the medications, they don't have the experts, et cetera. The best way to counter, in my experience, and I would recommend this to anyone, the best way to counter these immodest claims of causality is to just do the work. So we did that by launching, we thought tardily, although it proved to be probably the first community-based AIDS treatment program in the Global South. We launched a small program inside of the larger tuberculosis program that my Haitian colleagues called the HIV Equity Initiative. So it was always designed to it was designed to address an inequality that was not only had emerged, but was growing. And it wasn't a small effort in the sense of, we soon had far more patients in Haiti than I would see, for example, at the Brigham. And we used the same model of care, programmatic approach, as they say in public health, based on fairly successful, we thought, tuberculosis control efforts. And instead of calling them community health workers in Haiti, they were called accompagnateurs, those who accompany the patients. Many of them were living with HIV themselves and had been recruited through our clinical efforts. And we saw what we thought was pretty dramatic. And you've heard about the Lazarus effect from any, and I'll show you a couple of images in a minute. Just go back 1 second, please, Ishan. This is kind of an after picture, so I should have put it before, but this is the same patient you'll see in the next slide. Go ahead. That's before, and the next slide should be after. Now, this is a patient who later gained some notoriety, I might add, who presented, I think he was 31 years old. I do remember his lab results. He had a CD4 count of 36. He was carried in on a stretcher. We ended up making an acronym out of that, CIOS, carried in on stretcher, and had disseminated tuberculosis and had the courtesy to be smear positive. So there's no question about that. So we did the same thing that we were doing in those days, which we wouldn't do now. We treated his tuberculosis first and then put him on ARVs. And the reason I say he gained some notoriety is fellow PIH co-founder Jim Kim was at the World Health Organization at the time and said, I need some of the before and after photos to use in World Health Organization pamphlets to get us moving forward on the tardy but ultimately effective 3x5 initiative, get 3 million patients on therapy in the global south by 2005. I say ultimately successful. The date was missed by a little, but I mean, that's pretty impressive. I'll go ahead now to the next slide. All right. We also had other kinds of Lazarus effects, and I didn't mention this, but I mentioned it in the slide. For example, you can imagine what morale is like among the staff if you're losing patients to follow-up or to the unnatural progression of untreated disease. So I would also say this extra work with the tools of the trade, the staff, the stuff, the space, and the systems that we needed had an enormous effect on the morale of the staff. And this was seen everywhere as well. It's kind of a second Lazarus effect. But we also were able to use this model of care to promote other components of a basic primary healthcare system. And how did it work? Well, when you introduce HIV care to a place where there's a fair amount of HIV, you're going to see problems of all sorts, even if you only work with patients with HIV, which we could not. We knew we had to open the shuttered public clinics of central Haiti, but by providing comprehensive care for whatever they brought in. And it won't surprise you to imagine that a clinic that doesn't have much to offer doesn't have a lot of patients. So then this is just from the hometown of T. Joseph, the fellow I was telling you about. And this is where we met him. It's a small city called Las Caovas towards the Dominican border. And again, they were routinely seeing very few patients, and this just went through the roof. Yeah, that's the right number. That's the right scale. I haven't seen that again. And of course, if you're not testing for HIV, you're not going to find it. So that would go up. But we also had a couple of surprises that in looking for TB more aggressively, we would find a lot of TB patients as well. But as treatment proceeded, or as efforts proceeded, we'd find less and less of them. The joke among the community health workers when they saw this joke, they generated the data, but they saw the graph, was that everywhere Partners in Health went, there was a spike in TB cases, when of course they knew it was a spike in TB detection. We also saw beefed up prenatal care, family planning, vaccine administration. These are the things that please the public health community, even those who say it's not cost effective or feasible to treat AIDS in Africa or anywhere else. Next slide. And what happened next is not a story about Partners in Health, but it's a story about AIDS activism as much as it is about anything. And I have a couple of arrows here. I won't go into the details, but basically, as you all know, the systems were starved of any kind of resources to take on this or any other major threat to health. And so would this have happened without AIDS activists? I have a hard time believing it. The academics, I mentioned the Harvard consensus statement, because it was an effort to bring together academics who had probably been on different sides of the treat or not treat divide, and to reach some consensus that the integration of prevention and care was essential to addressing HIV in the world where it had already spread and had infected maybe 30 million people. And then some things began to happen. There was a United Nations General Assembly on AIDS, one of the first, if not the first, about a medical issue. The Global Fund was funded, and quite surprisingly to me and delightfully, President George W. Bush announced the launch of the President's Emergency Plan for AIDS Relief. And even though there had been those within the administration, fairly influential people who wanted all of that money to go to prevention and not care, that's not what came to pass. And again, activism played a role in that as well. So when you look at the increase in resources, then you're going to see what you would expect, which is a decrease not only in mortality, but a decrease in new infections, not uniformly, but in places where there were sound prevention, integrated prevention and care programs, that we began to see progress. Next slide, please. Now, Haiti, which gets a bad rap, just this past year has just been almost unfathomable in, a presidential assassination, kidnappings, disrupted, no fuel supply. A month ago, we were desperate, even wondering if we'd be able to keep the hospitals and clinics running, to say nothing of natural and unnatural disasters. But Haiti has done a very good job, even in the midst of all this, in the sense of having launched some of the first community-based AIDS programs, but also scaling them up with this funding. And in spite of multiple disruptions on the political front, steady, if slow progress, and faster than many countries with far greater resources. Next slide. And we'd also said, well, we kind of have a model to do this, right? The care for chronic diseases, whether we're talking about epilepsy, asthma, diabetes, severe hypertension, AIDS, drug-resistant tuberculosis, needs to be community-based. It needs to be focused on the concerns and convenience of the patients and not the providers. And that meant when there was community-based care with people going to folks' homes to deliver the therapy and see how they were, that the health centers and hospitals were less overwhelmed. It was health center enriched in the sense that most of the care that did require a nurse or a physician could be delivered in a health center. And when there were complications, as there always are with HIV or tuberculosis, there were hospitals there, public hospitals that had been rebuilt or built and able to provide those and other services. Next slide. So in other words, not much of a model, right? I mean, not very fancy, community-based, health center rich with hospitals. That's what got us invited to Rwanda well before 2005, but that's when it doesn't matter, for example, if one person or a consultant or a handful of people go. What we needed was a Partners in Health Rwanda, and that required getting everyone on board. And we were there by 2005. And our major partners were the government of Rwanda, particularly the Ministry of Health, of course, although it was clear that the executive branch really had a big stake in this. They were already putting money into really remarkable efforts that focus on gender equity, poverty, et cetera, remarkable efforts to scale up HIV care. But it was very limited at that point to the capital cities or a couple of other big cities. And I should mention the Clinton Foundation. Next slide. Now, some people said this model will never be accepted in Rwanda. I never heard that much in Rwanda, but meaning there's so much mistrust there. The society's been divided. They're not going to let people come into their homes to see how they're doing or test them or make sure they have medications. And by the way, it's also a clinical desert. There's not staff, they're not space, they're not systems. Well, we were sent At the time, there were of 30 districts in Rwanda, there were 4 without any district hospitals. And so we were sent to 3 of those 4, and we didn't even do it all at the same time. You know, it was really one year we'd go rebuild the hospital, reopen it. This is the first place we went, and it was an abandoned, I think abandoned. Some would say, well, there's a nurse there, but a nurse without the tools of the trade in an empty hospital. You know, it's hard to imagine that as a proper hospital. So we rebuilt that and used that as our home base. This is in a rural area, to launch the community-based efforts and to build or strengthen the health centers that were affiliated with that hospital. Next slide. And we saw the same kind of transformations there that we saw in Haiti. You know, if there's no hospital or if it's, you know, broken down, so either build one or fix it up. It's not rocket science. And these places, by the way, remain pretty beautiful to this day. Next slide. But the transformations that mattered most, next slide, please, were again the ones that anybody in a neighborhood could see. I remember when this man, and by the way, any picture, any photograph that I've used has been used with the blessing and even encouragement of the patient. So this man, his name is John, came in, and my Haitian colleagues in Rwanda. So of course, in order to launch a Haitian-style program in Rwanda, our Haitian colleagues went too. And they had already shown pictures, before and after pictures that were very dramatic. And, you know, people would ooh and ah and say, really, is that possible here? Could that really happen? And my Haitian colleagues said, you watch, you're going to see it unfurl right before your eyes. And this patient came in, he actually had, he had HIV too, but he actually had a high CD4 count. And what his most prominent wasting disease was tuberculosis. So again, as in Haiti, we started him on TB therapy and shortly thereafter, ART. Although the after picture here of John, I think was taken really even before he started his ART. And he doesn't mind when I make the joke that he goes from looking like Skeletor to looking like he needs a little Lipitor. Next slide. And I mentioned this earlier today in the ID rounds. Here's a study of, this is the first 1,000 patients that were enrolled in this program. Even though there's a fair amount of disruption, meaning back and forth movement across borders, and this is a small country surrounded by 4 others, we still could retain and care the vast majority of the patients. We had low mortality rates. And when we did have people who left, it was often because they went to another city. And if that city didn't have AIDS care, we tried to find a partner there or put it in place. So these are very respectable outcomes. Even in a study in the United States, you rarely got these kind of results. Next slide. So the transformation was in terms of the infrastructure, in terms of the people themselves, and the results were pretty apparent to all. And if you look at Rwanda, the difference between Rwanda and everybody else is that the government of Rwanda had a very ambitious AIDS plan. And even if they hadn't, they would have developed one, because they were not hostile to, but they did not want to see pilot programs. They wanted to do something for all Rwandans. And so they said to us very often, if you show us that this worked, we'll try to bring it to scale. And they did. And they were deemed the first over the line by the WHO criteria for universal access, well before even far wealthier Botswana. And again, I want you to see Haiti still is performing fairly well in spite of ongoing political disruptions there. Next slide. And what we also saw when we started looking at the data, because again, this shouldn't be just about HIV or any other single pathology, but about healthcare delivery in general, Rwanda showed the steepest declines in mortality, all-cause mortality ever documented anywhere at any time. And I wrote that in the New England Journal of Medicine, and been waiting for a long time for someone to say, "Oh no, that's not true. It was faster in Sweden during this era," or something. I think that claim holds. And so here in a graph that I'm really kind of surprised the New England Journal of Medicine let me include, I just compare what some people would consider non-comparables to look at the steep slope of the decline compared with other well-known success stories. And again, this is all-cause mortality, not just from HIV and tuberculosis, but HIV and tuberculosis mortality reductions were even steeper. Next. So, then because this is not just about one disease, some of the questions that we ask, and I'm here in Butaro, as Eric noted, this led to increased ambition for addressing other problems. And in one of those, I mentioned 3 hospitals. Well, this one we built from scratch because this was a district with over 350,000 inhabitants and no hospital at all. And in this town, which is now which is now a veritable oasis of education and medicine, there was not only no hospital, but no doctor, no electricity, or no water. There was a military encampment, in fact, as it's on the Ugandan border. And we asked the Rwandan government to take down the military installation and let us have this mountaintop where we would build a public hospital, which we did. And in that hospital, of course, which provides services for all comers, we started seeing lots more malignancies and started a cancer care program there as well. And I wouldn't mention it, even though I'm right there now, except that within a few years, 70% of all patients in the National Cancer Registry had been treated here, had been diagnosed here and treated here, or diagnosed and then treated here, which is pretty impressive if you look at a map and see how rural this area is. Next slide, please. Now, I wanted to stop here and just talk a little bit about the big picture with COVID before opening this up to discussion. If the lessons that we've learned in addressing HIV and TB, and as Eric said, this has been these gains have been sustained. In the countries where we're working and providing medical HIV care, which is many, Haiti, Peru, we have some work in the United States as well, but also Rwanda, Malawi, Lesotho, Sierra Leone, and Liberia. We have tens of thousands of patients in care who are doing well. Again, I don't see them very often because they're not very often in a hospital, and my medical colleagues don't see them either. In thinking about other complex diseases like drug-resistant tuberculosis, again, the same set of arguments marshaled against treating drug-resistant tuberculosis and some other ones too. For example, not cost-effective, not feasible, not sustainable, but also not prudent, impossible because of mutations. The list of excuses, as I tried to say at the beginning, was somewhat epic. Cancer care. Well, there are still people who would argue or think, they can't argue, that there is not a lot of cancer in the low-income countries, which, again, I don't know why anyone would think that was true, but it isn't true. And you don't have to look for HIV-related malignancy. In fact, the picture that Eric showed, which was from yesterday, the child in his mother's arms had acute lymphocytic leukemia and is starting to recover now. The list goes on, and you even heard this around COVID treatment centers. You can't have oxygen. Can't be maintained. So this is a chronic problem that we face not in global health, but whenever we're focused on the needs of populations living in poverty, and many of them are in the global south, and those in the global north, many of them are people of color, Black and brown people. The logic gets applied again and again. The contrary logic, and I think the logic that Tim Gill would approve, is that we start with an equity plan when we develop a new therapeutic. And I don't mean to be theoretical here, but rather to say when we know that something good is coming out, and that could be renal dialysis for people with chronic renal insufficiency, or kidney transplant, renal transplant. It could be the development of a new vaccine, like the COVID vaccines. It could be pretty much anything. In the case that I'm giving here, the new developments were not only the easy to use diagnostics, HIV serology and point of care tests, but also preventives. There's not a vaccine, but a multi-drug regimen given to a woman living with HIV who's pregnant prevents virtually all transmission of HIV to an unborn infant and probably to a breastfeeding infant. And that's worth bringing up because in the 3 districts where we're still working, of course, here the staff is all Rwandan as well, and I'm not required for anything. We've seen in a couple of those, 2 of those 3 districts, no cases of pediatric HIV in years. So not only have you seen a rapid drop in mortality, a return to work and gainful employment by so many, but also the near total disappearance of pediatric HIV. I remember when I was in training, we assumed that we would have a generation of American kids born with HIV, and we don't. It still happens, but it can be prevented. So the integration of prevention and care is relevant even when there's not a vaccine. And then finally, therapeutics. Whenever we have those countermeasures, is there a way to develop an equity plan at the outset? Now, I will say that with COVID, people in the know who realized that a novel type of vaccine was going to come along fairly soon, some people started agitating early on, thinking about how do we prevent vaccine apartheid? Can we have a plan, a series of distribution mechanisms, real political commitment, so that everyone who needs a vaccine, which may indeed be everyone, has access to it. And we failed time and time again. And so one of the questions we might ask is, can we reduce the time between the development of the novel technology, whatever it is, could be a surgical procedure, and the widening of this outcome gap? And I would argue here, since I'm giving this particular lecture, that this is one of the primary, if not the primary, human rights challenge of medicine and public health. What is the equity plan to distribute things that can prevent suffering and death and improve the quality of life? What's the equity plan for their distribution? Now, Rwanda, and I didn't want to use the same slides I used earlier in the infectious disease rounds, but Rwanda has in fact tried to adopt this as policy. So even before there was a single vaccine dose available here, the question about how to prioritize healthcare workers, frontline healthcare workers, including community health workers, and also elderly and health and other at-risk groups, that began before a vaccine was available. And so it may be that right now, Rwanda is certainly leading the pack among any of the lower income African countries in terms of vaccine coverage. It's not because they've launched mRNA vaccine production, although 2 days ago I was in Kigali for a very large meeting that aims to do just that. It's because they had an equity plan to distribute vaccine to those in need well before they could ever claim to manufacture it. We did not do that in the United States for COVID. The claims that we needed an equity plan to address COVID in the United States were sounded at the outset, of course, but the embodiment of these social disparities in diverging risk for infection, but also for survival once infected, and also for transmission to others, which we know something about thanks to contact tracing, especially when genotypic tools are used. We have not prevented that. And some would argue, I would be comfortable arguing, and maybe this will come up in our discussion, that the United States formed uniquely poorly in responding to COVID because we lack an equity plan and because our public health systems, our delivery systems in public health particularly, and national health insurance systems have been so weak. And so we see, it's almost like being a Cassandra, predicting that this is going to happen and seeing it happen is a very disturbing thing to do. And at the same time, now we have new medical countermeasures coming on, oral therapies, for example, although I wouldn't want to dismiss antibody therapies either, or oxygen. So this is, this is the moment we live in. We've learned a lot, I think, more than from any other experience or disease. We've learned a lot from the HIV experience. The tuberculosis experience is not a place we should go for uplifting messages and lessons to respond to the next challenge, whatever it may be, or the current one, which we're all living through right now. And I just want to open this up to discussion by noting that the people in this picture, this is from today. This is the white coat ceremony that Eric was good enough to mention. We, frustrated by our inability to have effective equity plans when we know that new and good things are coming down the pike, we decided that we'd start a whole university focused on global health equity, and within it have a medical school, nursing programs, executive education programs, et cetera. And I think as a medical educator, first of all, I'm very grateful for the students I have at Harvard Medical School, because there seems to be a great deal of awareness about these problems among all of the students I meet. And I meet most of them because they're required to take a social medicine course. But in Rwanda, what we have seen is each generation seems more committed to this. And again, this is a group of students taking an oath, which involves global health equity front and center, of paying attention to the needs of the vulnerable, the excluded, the poor. And I'm hoping that some of the lessons that we're learning here can be of use in our own country as well. So let me open this up to a discussion. That's always the most fun part of this, and I hope I haven't gone over in any sense. Thank you.
Dr. Farmer, thank you very much. Inspiring and brilliant, and we do have time for discussion. So I think it's good. We have more questions than we have time for. That's excellent. But I'm going to kick it over to Dr. Peschla first. I know he has some questions and questions from the ID division.
Yeah, thanks very much, Paul. Before I throw it open to general questions, I wanted to ask you two questions. One kind of specialized, but it gets at the nihilism, therapeutic nihilism thing you mentioned this morning and again now. You know, the we can't do that in this setting, can we question? And how much has same-day initiation of antiretroviral therapy for the general audience? You see the patient, you diagnose, they go home with pills. How much has that been done and effective in Haiti and in Rwanda?
Well, in Haiti, one of our mutual colleagues and friends, William Pop in Port-au-Prince. First of all, I also want to brag about them. The group's called Geskio, but they published the first papers about HIV in Haiti, and they were some of the first papers about HIV in the Americas. And they have, because they're in an urban area, they have even more patients than we do. And they launched same-day initiation well before we did. And they've had great success with it. And again, the big problems in the urban areas there have been political disruption, inability to travel safely, et cetera. We've had less of that in rural Haiti, but plenty of it. In Rwanda, it's really taken off even more on a national level, and so that the policies are being reformulated. This is another thing I've found so admirable in Rwanda is they use new data to shape their policies and reformulate them again and again and again. And I can't even keep up with what they're doing in HIV. My closest colleague here, who's the president of this university, was, as you know, Eric, is Agnes Binagwahu, who was the AIDS program director before becoming Minister of Health. So I learned from her a great deal about how to incorporate new data, even if it's being presented at CROI or some other scientific meeting. It's new. If it's compelling, they're willing to take it up. Across the continent, I know less about what's going on in Southern Africa. There have been some large programs, not just in South Africa, but in Southern Africa, But whether or not they become national policy yet, I'm not sure. I should know that. And maybe you know for Zimbabwe what they're doing there. But I think it's helped a great deal. What's helped even more, though, I believe, is the ready access to community-based services, which require community health workers. In the United States, for year after year after year, we were told that this was not in the insurance scheme, not sustainable. This is in the United States, community health workers for AIDS, TB, or other chronic ailments. And it's really only this latest catastrophe that's allowed us to recruit a lot of community health workers and contact tracers in Massachusetts. And again, it strikes me as uncomfortable at the very least that depended on having a very visionary governor, Charlie Baker, who was so, and as far as I know, he's a Republican, who was so disheartened by the lack of urgency around the federal response, which he thought required contact tracing and social supports to those isolating, that he made it policy and recruited partners in health to do a lot of that work with the local public health departments. And at one point recently, we had 2,000 community health workers, contact tracers, or patient connectors on working with us at Partners in Health just in Massachusetts. So I know I switched from same-day initiation rapidly to COVID, but I want to say it's quite unusual in my experience that you have political leaders who are on top of the changes and recommendations. And sometimes I would blame us. Again, the people in our communities who are naysayers, who say it's not feasible, not possible. That nihilism, it doesn't really come from patients. It doesn't come from activists. It doesn't come from their families. So who does it come from? And we need to be pushing political leaders, whether they're governors or mayors or the president, to keep altering the policies to make them better. And as bad as this past 2 years has been, and 800,000 dead it's hard to beat that. I am sensing, and I believe you are sensing it there too, there's more of an opening for some of these policy changes that we've needed so long. Rwanda has 100,000 community health workers at least. They have palliative care community health workers. They have communicable disease community health workers. They have mental health community health workers. That's what we need very desperately in the United States as well.
So I'll circle back to my second question if we have time, but Jeff, why don't you bring in some questions from the audience?
I'd like to ask one from our house staff. And it starts with a compliment, which is that you are an inspiration for so many people that went into medicine. And the question, Dr. Farmer, is what is the biggest mistake that you see from new energetic physicians as they enter the world of advocacy and global health?
Well, I don't want to sound overly harsh because I'm not that kind of person, but I routinely see, when American colleagues, students, trainees, and even colleagues, end up in the medical desert, they make some pretty reliable mistakes, and they're not mistakes that could be countered by a concept like cultural competence. The mistakes really call for cultural humility. So, for example, in Rwanda, we launched with the Rwandans a huge project, an 8-year project to try and address the glaring deficiency of specialists and subspecialists here in Rwanda. And again, they were getting from the international policy advisors, you don't need orthopedic surgeons in Haiti, you need nurses, as if orthopedic surgeons and nurses weren't both needed. And so when they rejected that, which is another kind of nihilism as well, when they rejected that, they said, well, we want to train oncologists and psychiatrists and hospital managers and nurse specialists and nurse. And so this program began, and the clashes that happened, that ensued, it was a successful program by any means, but the cultural clashes were often when the Americans and sometimes Europeans thought that they were the ones not just in charge, but the ones who really cared most about the patient, and so there are those kind of problems. And I always counsel my trainees and students not to do that. Another that I've seen just as often among Haitian and Rwandan elite professionals as among American elite professionals is a tendency to blame the poor for their own problems. That strain has to be countered by policy that would prevent them from having an impact, whatever their ideas might be, on the need for things like food security, insurance programs. And again, the Rwandans have done a terrific job. About 93% of Rwandans have health insurance. Indeed, one patient I saw last night had a young woman, catastrophically ill with a very rare malignancy, GTN, something that most ID doctors or internists have never seen. I've seen it often, but she'll pay about over the next year for multiple courses of chemo. The one she started today is a 5-drug regimen. She'll pay about $10 for that because her insurance has a fixed copay, which is measured in pennies, not dollars, and she won't have to. That's the whole idea of pooled risk, right? So we also need to get our young enthusiasts focused on some of these things that we never learned about in medical school. And frankly, I don't even find it interesting. I'd rather talk about, superstition, or strange beliefs than I would about healthcare financing. But is it okay for doctors and nurses to know almost nothing about it or about health insurance? So this is another mistake. It's not their fault that they didn't learn about that in medical school or nursing school or residency, but it is a problem. So some of the classical things you hear about cultural imperialism, they don't take the form I would have assumed. Again, the assumption that you're the most concerned person, that's just not true. But by and large, the reason I'm smiling and don't want to sound harsh is I made a lot of mistakes when I was a young enthusiast, and I'm really just trying to share the mistakes that we made so they might not make them. But they inconvenience our colleagues who are, of course, the quasi totality of them are Rwandan, Haitian, Liberian, whatever. So a little bit of homework on that front would help. During the Ebola epidemic, and I know this is a longer answer than you want, I knew that I was going in there for one reason and one reason, invited in for one reason only, and that was to help strengthen the health system, take care of Ebola patients, and reopen these shuttered hospitals and clinics. But I still wanted to learn about the place. If we had all gone in there, though, saying, hey, I want to be an expert on, culture in coastal Guinea or Liberia, we were looking for nurses with skills putting in IVs. That's what we wanted. So it's also kind of unwelcome to get too involved. You know what they call it in Sierra Leone? They call it native business. Like, don't get involved in native business, do your job. And then if you're lucky, as I was, maybe you can learn about it as well. But by and large, I think this growing enthusiasm among young Americans, and I don't know, maybe Europeans as well, in global health is so welcome as long as they know it's about global health equity. And so we kind of stopped using the term global health, not religiously, but we try to tack that equity part on too, because that also helps the well and professional remember that it's not about them, it's about the patients that we should be serving. I hope that didn't sound like too much of a preach.
No, I think that's exactly what people wanted. And in fact, you managed to get to a couple other questions through your response. So I really do appreciate it. Dr. Farmer, out of respect for your time and our audience, it's about 5 after now. So I want to make sure that everyone can get where they need to go. Joining us from Rwanda today, I can't thank you enough for doing this. And Dr. Peshla for honoring Tim Gill at the same time. Thank you all for being here.
Thank you so much for having me. It's been a great day.